everyone. My name is Jodi Lyons, and I'm your host of Your Need to Know. Today, I am thrilled to have Dr. Ketan Petal with me. He's an affiliated physician with National Spine and Pain. In our previous discussion, we had talked about various types of pain and what you can do about them. Today, we're going to take a little bit of a deeper dive for, and correct me if I get the term wrong, minimally invasive implantable options. Is that about right?
You got it.
Hey, excellent. So Dr. Petal, welcome back. I'm so glad you're here.
Thank you so much for having me.
Great. So why don't we do a little bit of a recap from what we talked about the other day, which is when you would even consider doing implantable anything and where it fits in the spectrum of pain in general.
Absolutely. So last time we spoke, I discussed all the different options that are available, and I tried to simplify it to where you can kind of get a sense of where you are on the spectrum, whether it's conservative options, whether some of the basic procedures that we do, anywhere to surgical options, and then I kind of touched briefly upon some of the implantable therapies, and that can include options such as something called spinal cord stimulation, which has a few subsets there, which I hope to be able to go into more detail today, and then some other options as well. But that's really what we had discussed, and the spinal cord stimulation is an option for certain patients who, to be frank, don't really have that many other options.
Okay, so let's first start with what spinal cord stimulation is, and then if you can also explain what you mean by they don't have a whole lot of other options. Because my guess is that a whole lot of people who are listening are thinking about you're taking a big knife, going all the way down the side of their spine and, you know, something not quite right, or that you're trying to just pump them full of pain meds. So maybe we start, let's flip it a little. So what is it that they have as an option, and then what is spinal cord stimulation really?
Absolutely. So we use this for a few different type of pain conditions.
Okay.
And here's what's interesting. I'm going to throw this fact towards you.
Okay.
The first spinal cord stimulator was implanted in 1967.
I had no idea that the technology was that old.
1967. So let's think about this. This has been going on for decades and decades. And many individuals have no idea what it's about.
Right.
And here's where it gets really kind of interesting is that if we think about it, we sort of reverse engineer this. In 1967, the neurosurgeon at the time and the electrical engineer, I believe it's electrical engineer, but it was an engineer that was involved when they first made these devices. They decided that they would put the wires in, turn it on, and see what happens to the person in terms of pain relief. So at that point, they sort of decided, let's try to see what happens. And over the next few decades, our research got stronger. We really delved into the basic science of what's happening. And here's where it gets really cool. In the past probably 10 to 15 years, it's not just an electrical signal that we send and we're trying to mask pain, right? So if you think about it, if you bump your elbow and you kind of rub it, you're trying to prevent that pain signal from hitting the brain. You're trying to mix it up with a signal, hey, I'm touching my elbow. So what this device is doing is actually sending signals through a wire to the spinal cord above where the problem is.
So between where the injury is or the problem is and the brain.
Exactly. So nerves in the spinal cord go north and they go south.
Right.
The brain sends signals south, but also there's signals sent from wherever the problem is up north.
Okay.
And what the spinal cord stimulator is doing or attempting to do is change that signaling so that you no longer are being affected by that pain. Now, what's interesting, it's really cool.
So it's basically interrupting the electrical signal. And
exactly, but it's not even just electrical.
Okay.
What's happening is, what is a nerve? A nerve is just a type of cell that's transmitting really different chemicals. And what is changing is it's changing how those nerves interact with each other, and on a molecular level, changing how we perceive the pain that's occurring.
That's amazing.
Tell me more. It's really kind of cool. And here's what's interesting. Someone may say, oh, well, will that prevent me? Will that cause me to injure myself because I can't feel anything? Well, no, because it's not affecting our perception. You can still feel, you can still do what you need to do. Just give you an example. We've had, gymnasts who we've put these type of devices in, even those as young in their 20s. And I've even implanted these type of therapies to those individuals who are in their 90s. So it's quite a gamut of individuals who can benefit from it. But here's where it's kind of interesting. The most common indication for this is those individuals who've had back surgery, sometimes multiple back surgeries, who have persistent pain in their back and legs. And those are really probably a majority of the folks that benefit from this. but there are other indications as well. There's recent FDA approval for individuals with neuropathy from diabetes. So a lot of these individuals really don't have a lot of other options, and so you can use this type of modality for that type of patient. There's certain other pain conditions. There's a condition called complex regional pain syndrome. It used to be referred to as RSD, or reflex sympathetic dystrophy. Maybe some individuals may be familiar with that, and boy, that is a god-awful disease, and it can be very challenging for a lot of individuals, and there's a lot of data to support the utilization there. And believe it or not, in Europe, they sometimes use it for folks who have chest pain from angina, who have cardiac disease, and those who have vascular disease in the legs, who have that kind of like claudication, which is that kind of like crampy feeling that they get because they're not getting appropriate blood flow to the leg. So again, I'm going on and on about this, but there's a lot of different types of...
I'm fascinated by this. So there's multiple uses for this particular procedure.
Yes.
So can you explain to me what exactly the procedure entails?
Absolutely.
What does it look like from your end and the patient end?
Absolutely. So what's interesting about this is that it's one of the few therapies that exist that are to this level where you can actually trial it. So this is really where it gets kind of interesting.
Okay.
Let's say you're my patient and we go through those appropriate options and say, look, you know what, you're to the point now where this is an appropriate option to consider. There is a trial, and I cannot emphasize enough how important that trial is. And I always tell the patients as well, is like, listen, with this trial, it's really their chance to really see if this is going to be something that's going to be appropriate for them. And how many other type of procedures and therapies do you have the opportunity to do that with?
You don't. They do the surgery and it either worked or it didn't,
Exactly.
Right?
And so that's
so what does a trial look like?
Absolutely. So we actually do this procedure, believe it or not, in our offices. You actually come into, absolutely, just like any other injection. Now, of course, there's a few more steps involved in it, and we have to do a couple of other things to make sure that we're maintaining sterility. But we do right there in the office, at least with the trial, where you would come in and we would use image guidance, typically an x-ray machine such as a fluoroscope, and we would basically numb where we need to enter and then guide the needles to introduce the wires into the epidural space, same space as perhaps someone who's getting an injection, same space as a laboring woman gets medication if they're having a labor epidural. So it's really not that much different in terms of where you're putting them in. It's just that we're putting it a little bit higher up into the spine. And so what we do is, instead of instilling medication, we put the wires in and then sterilely secure it to the skin. So, and then individuals go home and then they trial it out for typically a few days to about a week, and then they see if there's any benefit from it. Now, it is an active therapy in the sense that there's constant communication with many of the device representatives as well as the offices to make sure that there's not any adjustments or tweaks that need to be made. But again, it's really their way to trial to see if it's going to be appropriate to covering their pain.
So basically, you're injecting wires into the spine, and then there's some sort of device attached outside the body?
And it's all wireless now. You know,
it's all wireless.
It's all wireless now. You know, back in the day, and I suppose I'm still young, but I've been doing this for a long time. You know, even early on, it was a wired device. And again, what's really cool that's changed from the 1960s till now is the wires are getting better, the technology is getting better, the batteries are getting better, a lot of the hardware is getting better. But what I'm more fascinated about is that our understanding of what's happening at the molecular level in the basic science is getting better, to where in the past, in order to be able to get pain relief, you would get a stimulation, you get this pleasant tingling that you would feel in your back and legs. Well, now we've gotten to the point where we can mimic the body's own signaling. And by doing that, you don't necessarily feel any tingling, you just don't feel the pain anymore. And so we're getting better and better, and there's new technologies coming out there with closed loop feedback to where we can get a sense of where your spinal cord is in this sort of fluid sac of spinal canal to automatically adjust the signaling to be able to accommodate for when you're sitting or standing or laying down. I mean, again, I can go
wireless?
It's all wireless.
That's amazing.
It's really, again, you can see I'm very passionate about it. And
absolutely.
And there's a lot of cool things coming down the pipeline and so many different changes coming through where the outcomes are only going to continue to improve.
So it's something that, I don't mean to minimize this at all, it is still a big deal.
Yes.
But it's not the big scary, as they say, the big scary hairy deal that people were afraid of.
Absolutely. Now the fact that we're able to do these with such minimally invasive approaches, I think it becomes more accessible to individuals who it couldn't be accessible for before. I'll give you an example. When we do the permanent implantation, that is still a surgery, but for many individuals, you don't even need general anesthesia. We do it with sedation and local anesthetic,
wow.
and it's an
Okay.
outpatient surgery. You go home the next day, or you go home the same day. And again, I think that gives you a sense of, hey, this is maybe not as big and scary and hairy as we initially thought. And again, I do want to point out, even though I have a lot of enthusiasm for this, you really need to discuss with your providers, is this the right thing for me? Because the reality is that it can be amazing for one person, but
And
it
not
may
for
not
the
necessarily
other.
be for you. And I think that not only technically do we have to do a good job with the device, but we need to really make sure, hey, is this the right type of modality for this person at this time? And so I cannot overemphasize that either, because the last thing I want to do is put this into someone and they not get the benefit that they're wishing for. So I
Right,
think
so-
that's very important to keep that in mind.
So it has to be the right thing for the right person.
Yes.
And the only way to decide that is to go through your decision tree and working with the patient and getting the
Yeah.
patient history. But let's say it turns out to be the right thing.
Yes.
So basically, they can have this procedure done. There's a trial period, and then you go in. What's the next phase after that trial period?
So during the trial period, the wires are actually in, and then we'll pull them out. And then what I actually tell my patients is, if they're not sure, or even if they know, is go home without it. See how you feel over the next couple of weeks without the device in.
Okay.
Because I think that there's information to be gleaned from both the trial and without the trial. Because you're able to
Okay.
kind of see how you did with it, and then how's life without it. And most people are going to know. Was their life better with it than it was without it? Again, I like to keep things very simple. Now, once you decide to go forward and you and your physician decide this is the right thing to do for you, then it's proceeding with the implantation. And that's, as I discussed, typically done with sedation and local anesthetic, and it's done as an outpatient surgery.
That's perfect. So we're getting ready to head into a break right now. When we come back, I'd like to go into this with even more detail about what the implantation is like, what life is like after the procedure, things people need to watch out for, and things people can expect. So for everybody out there, please hang on and stay tuned. We'll be back right after this short break.
Opiates has taken everything and everyone I've ever loved away from me. Everything.
I blew my ankle out and I got prescribed pain pills by my doctor.
If making my detox public is gonna help somebody, I'm all for it. I just wish I would have had a warning.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
Hi. You think you're probably sober?
Yeah.
But you're thinking about taking the back roads home, just in case. If you're probably sober, then why would you do that? Good choice.
Probably okay isn't okay. If you see a warning sign, stop and call a cab, a car, or a friend.
That's a full glass of wine. I'll be chatting you later.
What are you looking for?
Caitlin, be serious. Now take the oath. Come on. I'm totally taking this seriously. Okay, I'm ready. You may begin. I pledge that I will never meet in person with anyone I first met online without checking with my parent or guardian. And furthermore, if my parent or guardian agrees to the meeting, it will be in a public place and my parent or guardian must come along. Do you pinky swear? I do.
When you teach your kids about internet safety, they'll pass it on. For more information, go to cableclicksmart.org.
Hi, everybody. Welcome back. Once again, I'm Jodi Lyons, and I'm here with our guest, Dr. Ketan Petal, who is an affiliated physician with National Spine and Pain. And before our break, we were talking a little bit about spinal cord stimulation, and we were just getting to the point about what happens after the trial period. So can we start with, let's say the person has their trial,
Yes.
and they decided they like it. What happens next?
And as I stated before, after the trial, we have a discussion and here's what I would tell folks is the trial is like dating or like being engaged.
Okay.
And the permanent implantation is like marriage.
Okay, I like
Right?
that.
But it's important because anytime you have a device, and what I would say is think about this as like a pacemaker.
Okay.
Pacemaker sending signal to the heart. This is a similar type of device sending signal to the spinal cord.
Okay.
But what would happen is, let's say we kind of go through our thought process and the patient's like, you know what, this is perfect for me.
Okay.
The next step is typically going to be the permanent implantation. And there are a few ways to do the implantation. If you look at the data across the country, 80% of the implantation that are done around there are what's called a percutaneous implantation, which is what I do.
Okay. So
Basically,
what does that mean?
that is in the similar way that we put in the wires during the trial,
Yeah.
we do that same technique for the permanent implantation. Typically, we do it at a surgery center. In some locales, they may do it at a hospital.
Okay.
But in most situations, it's outpatient and you go home the same day. Just to give you a general sense of the level of invasiveness we're talking about, there's no hospital stay.
Wow.
And for many individuals, we don't even do general anesthesia. We'll do a heavy sedation, so you're asleep,
Okay.
but we'll do it with that local anesthetic and you can tolerate everything just fine. And so just to give you a sense of the level of invasiveness, you know, we think about these things and it can be scary.
Right.
I mean, this is kind of
absolutely.
like, to me, like you're putting a wire in my back. Like that's
Exactly.
a little bit.
Well, I'm thinking there's a wire and a thing the size of a backpack going in my back.
No. It's
So
very
what does it
subtle.
really
and,
look like?
and here's what's really kind of cool. And a lot of the companies out there have their informational websites to look at the specific products.
Okay.
And there's a few companies out there, and I would tell any patient out there, you know, a lot of the different physicians will have their reasons for choosing one company or another one. And I have
Okay.
a couple that I work with. But by and large, with these large companies, a lot of these are international companies, you're going to have a good outcome. You know,
Okay.
they're generally going to be very similar across the board. They may have their pros and cons for a specific situation, but generally speaking, you're going to have a good outcome. And so I'll give that caveat that there's not just one company out there making one device. There are a
there's
few different ones out
multiple.
there. And,
Okay.
and someone may have their reasons for choosing one or the other one, but they're all trying to advance and continue to get better. And every year, someone has a new technology that the other person mimics and comes
Okay,
up with.
great.
So
So-
it's competition is just good for the patient. Let me tell you.
Absolutely. So how big is a device?
So here's what's interesting. So the wires are very, very thin. You know,
Okay.
wires like the size of the thick, like thinner than a shoestring. I mean, we're talking
Oh,
about very,
wow.
very, very, very
Okay.
thin. And so you use that, and that's going to go into the epidural space, and that's what actually is going to be carrying the signals to the spinal cord.
Okay.
Now, the battery that we implant is typically done in the small of the back.
Okay.
And depending on the type of battery, some of them can be rechargeable, where just like you charge your phone, you may a few times a week charge it for maybe an hour or two,
Okay, you're
depending
gonna
on
have to explain that one. How
Yes.
do you possibly recharge a battery in your back?
So there's just a wireless charger, just like you know you have your phone where you have
Right.
NFC charging, something similar to that. And so you can
just
do
sit
that.
down and
Yeah,
put the
you charge
charger?
it for a couple hours while you're watching TV
That's
and you're good to go.
amazing. Okay.
And those are going to be much thinner batteries, right?
Okay.
And they last for a long period of time. Many of them can last for 8 to 10 years. And you
Oh.
may have to replace the battery, which is a 15, 20-minute outpatient procedure to do so. Now,
Wow.
for some individuals, they may use a device that's non-rechargeable, and they may hold their charge for anywhere from 3 to 7 years. Again, and there's reasons to pick one or the other one.
Okay.
But those are going to be a little bit bigger, but again, they're still quite small. You know, they're not going to be really that big. I mean, they're maybe a couple of, you know, an inch, a couple of inches, and then the depth is really quite small as well.
That's amazing because I think most people are literally picturing something the size of a giant cell phone and twice as thick sticking out somewhere. So
You know-
that's just not really the case anymore.
Absolutely. I mean, if we think about it, if they could apply this technology to my cell phone, I would
Yeah.
never need another cell phone again because I could charge it forever.
Exactly.
But the battery technology has improved certainly since the 1960s that they've been doing this. And, you know, the batteries are getting
amazing.
smaller and thinner. And, you know, I will say that for many individuals, some folks, especially with the newer batteries, don't generally realize that it's there. So they're really quite small.
And does it affect the person at all? Like, could you still go? You probably couldn't get an MRI with it, but could you?
You can.
You can?
Yes, so here's where it gets interesting.
Okay.
I mentioned to you a lot of the advances that have been made over the last few decades.
Yes.
One of them is MRI compatibility, because that is a big concern for many individuals. And so many of the devices are MRI, I'm going to say conditional, because I don't want to get too much into the terminology.
Sure, yeah.
You can't always just jump into an MRI machine.
Right.
But for most individuals, you can still get an MRI with these newer devices. And I think that that's very, very important, because you can still do what you need to do. And I'm going to sidestep here for a minute.
Sure.
I always tell folks, if you get a permanent implantation, such as a spinal cord stimulator, it is a tool to treat your pain.
Okay.
It doesn't mean that you'll never have any other issue ever again over the course of your life. It's a tool to treat your pain, and for many individuals, it can be an absolute game changer.
Absolutely. I would think quality of life is huge.
Absolutely.
And I would assume also mood, anxiety, and depression, because we know that that's very closely tied to pain. And what a lot of people don't know is also cognition because of constant pain.
Absolutely.
Cognitive issues. So I think this is amazing. And we have roughly 5 minutes left, and
Yeah.
I could go on forever about this.
Oh, I could definitely talk about this for hours.
So we've gone through the procedure, we've gone through how to do it. What can somebody expect at the end of it? I mean, it's not going to be like waving a magic wand and all of
No.
a sudden they're not in pain, right? But what happens, and then what does it free them up to do that could really make them have a quote-unquote normal life?
Absolutely. So once the implantation is in, then there's a couple of things that are going to happen over the next weeks and sometimes a few months.
Okay.
So the wires sometimes take a few months to fully scar into place and become stable. So
Okay.
typically for about 4 to 6 weeks, we do tell folks that they don't want to do a lot of bending, lifting, twisting,
Okay.
because we want everything to kind of heal up and get settled. Now, thereafter, once things have healed up, believe it or not, most individuals can go do almost anything. I mean, again, I've put this in individuals who are athletes and gymnasts. Fortunately, not too many of those individuals need them, but the ones that they
Right.
do, we've been very helpful for them. A lot of individuals who have very, very, very tough and challenging cases have had a lot of benefit from these. But over that course of weeks to months, it's not uncommon to need to adjust and program the device.
Okay.
So just like any other electronic device, we can actually go in and adjust the parameters. Now, someone out there may think, this is too complicated for me. This is an electronic device.
Well, I was
I'm
just
not
thinking
very
it sounds like hearing aids. You go in, you get them adjusted.
So here's where it's kind of exciting.
Yeah.
I can make this as simple for you as you want. If someone is not very technologically savvy,
Yeah.
we can make it as simple as on and off, up and down.
Wow, okay.
Now, we have individuals who are very technologically savvy, they want to have a lot of control over what they do. We can make it so that you have multiple programs, because not just sending a signal to the spinal cord. There's nuances, there are different types of signal. We can adjust how frequently the signal, the width of the signal, the intensity of the signal. I mean, like I said, there's so much subtlety to this
Wow.
that we have control over. And so someone who has a lot of different types of pain, where the pain may affect them at different parts of their day, we can actually have a lot of built-in programs so that the individual can select what they need at what time.
So it's almost like your cell phone, where you can do the do not disturb at a certain hour and
Yes.
more active. So it's really technology. I mean, that's amazing.
I mean, it is. And
it's
like
a
I said,
real medical device.
even over the past decade, I've seen such incredible advances, not just MR compatibility, but again, we're mimicking the body's own signaling. The body has an amazing ability to heal itself. We all know this. But what happens for a lot of these individuals who need these type of devices is sometimes that process is dysfunctional.
Right.
And we need to introduce devices like these for many individuals to be able to help them out and get them over that hump and allow them to be more functional. And there's a lot of cool things coming down the pipelines. I'm very fortunate that I'm in the know, because I work with a lot of the individuals who are doing some of the research.
Right. So tell us some of the secret things to look for.
Yeah, so
secret because it's on TV, right?
Absolutely.
So what's going down the pike?
Well, you know, a lot of, and I'll give you some, I'll talk about one option here.
Okay.
So we know that the spinal cord where we're sending signal to, it's free floating in a space where there's fluid, right? We're surrounded by fluid in the spinal canal. And what happens is there's a change in how much distance when we move, like the cord doesn't just sit there in the middle.
Right.
When we kind of bend and twist, it sort of sways in that canal. And I don't want to get too into detail, but think about it this way: when the cord moves away, the signal needs to accommodate to be able to continue to send that same level of signal to the cord. Now, when it's closer, you want to be able to have it adjusted. And so, I don't get into too much detail, but let me just say that there's technology coming out that can actually, in real time, determine what's happening at that level of the spinal cord to be able to make adjustments. And I'll leave it at that. I don't want to say too much, but I will say that further technology is coming down that I think will make the process and the signaling more efficient, which we hope, and the research looks like it's panning out. Because again, I don't want to speak to theory, I want to speak to data, right? But I think that some of this stuff is panning out to show that it may be improving the outcomes that individuals are experiencing. And so that's really where it's kind of cool. And what I love about our field is that there's ongoing advancements in what we do. Like I said, there's no panacea that's going to fix every problem that individuals have. And I've had some individuals who, even in the past, like 10 years ago, they tried the device and it just didn't work for them at that time. To where, you know what, it was appropriate to do it again. And we went through, and for many of those individuals, it was actually helpful because of the changes that we had this time around. So again, new technology, things are changing, and again, it's really cool. I mean, the things that we can do nowadays for our patients.
That is great. So it is reasonable that somebody who goes through all of this, if they're an appropriate candidate, can go back to a life where they're doing things they couldn't do before. And can I also assume that they would be less of a fall risk because they'd be not hunched over, they could stand up more, they could do more exercises to strengthen their body and not be in pain? And is that a reasonable assumption that they're, you know?
I would say this. I think that the goal is obviously the pain should be better. When pain is better, most individuals, their functionality is better. And I think when their functionality is better, all these other things sort of fall into place. And so I think that that's a reasonable assumption. Now, I would hate to promise X, Y, and Z, but I do think that it's a reasonable, and I think the goal should be not just pain relief, but functional improvement.
Well, that makes sense.
And that's going to lead to all sorts of other benefits. And the reality is what we do on a daily basis, it's hard. We have a lot of folks who really are suffering quite a bit. And I'll leave you with this point. I always joke with my patients, said, look, you've had 10 years of pain, give me a couple months. There's no quick fix. There's no quick fix for a lot of these things. But if you go through the process, starting with the conservative all the way up sometimes when these implantable therapies become appropriate, if you walk that pathway appropriately and you're making appropriate next decisions about your care, then at the end of the day, for many individuals, it works out.
Perfect. Everybody, thank you so much. That was a great way to end this. Thank you for watching us on Your Need to Know.